two beautiful countries in the world, India and Australia. This is eCritCare podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare podcast. This is our 114th episode. And today I'm joined by my co-host, Dr. Jose Checo. Welcome, Dr. Checo.
Hi, Swapnil. Nice to be back at this podcast.
Today is our journal club, and we have decided to discuss another very landmark randomized controlled trial, which was recently published in New England Journal of Medicine. And it came from ANZIC CTG, really well-conducted trial and really answered some of the important questions. And the trial called as PATCH trial, which tested the role of tranexamic acid in pre-hospital setting for severe trauma. Now, as we all know, the trauma is one of the leading causes of death among young people. And most of these deaths are really preventable because most of the deaths in trauma happen due to hemorrhagic shock. And the coagulopathy involving trauma is usually secondary to plasmin-mediated fibrinolysis resulting from the tissue injury and hemorrhagic shock. And tranexamic acid as an antifibrinolytic agent is thought to be effective in the treatment of trauma-induced coagulopathy. Now, in this podcast, we have discussed CRASH-2 and CRASH-3 trial, which demonstrated the benefit of tranexamic acid on mortality in trauma and also in the traumatic brain injury settings. And key messages came out of those trials is tranexamic acid administered within 3 hours after injury will reduce the 28-day mortality. That was a message from the CRASH-2 trial. While in the CRASH-3 trial, tranexamic acid administered within that early phase will help to reduce the mortality in mild to moderate traumatic brain injury. However, CRASH-3 trial did also demonstrate that the survival, even though it's improved, there will be a lot of patients will not achieve the Glasgow outcome scale more than 4. Now, the argument against those trials, despite those trials showed mortality benefit, where most of the participants in those trials were recruited in the countries, especially the subcontinent countries or third world countries, where the trauma systems are not very well developed. And because the trauma systems are not very well developed, the tranexamic acid shown to have a benefit. The another criticism was the follow-up was only for the 28 days, and we don't know what's the effect of tranexamic acid on 90-day mortality or 180-day mortality in the same setting. Having said that, the tranexamic acid has also shown benefit in other contexts. For example, in the postpartum hemorrhage done by the Ian Roberts and his group from UK. There are few available evidence around tranexamic acid with regards to its benefit. And we covered this topic quite extensively in our recently published book, Controversies in Critical Care. So if you want to dive deeper into the whole topic, please have a read of that topic in that book. So today we are going to discuss about the PATCH trial, which evaluated the efficacy and safety of tranexamic acid therapy in patients with severe trauma who were at risk of trauma-induced coagulopathy. And the hypothesis was the tranexamic acid initiated before hospital admission in advanced trauma systems would result in a greater percentage of patients surviving with a favorable functional outcome at 6 months than compared to placebo. So, Dr. Checo, can you please walk us through the methodology and the results of this trial, please?
The PATCH randomized controlled trial was conducted over a 7-year period between July 2014 to September 2021 by 15 emergency medical services across 21 hospitals in Australia, New Zealand, and Germany. Adult patients with severe traumatic injury treated at the scene and transferred to trauma centers were eligible. Patients were at a high risk of coagulopathy based on the COAST score. They used the COAST score to identify patients who are at a high risk of coagulopathy, and the cutoff was a COAST score of 3 points. And this includes criteria like entrapment, systolic blood pressure, temperature, if there is hypothermia or not, the use of chest decompression, injury to the abdomen and pelvis. So they administered the first dose of tranexamic acid within the first 3 hours of injury and prior to hospital admission. Randomization was to either tranexamic acid or placebo and carried out in a 1-to-1 ratio. They excluded pregnant patients and those who resided in elder care facilities. These were the exclusion criteria. In the intervention group, tranexamic acid was administered 1 gram over 10 minutes as the initial bolus dose at the scene or en route to the hospital. A further dose of 1 gram was administered as an 8-hour infusion, pretty much like the CRASH 2, CRASH 3 trials. In the control group, they received an identical placebo with a bolus and an 8-hour infusion, similar to tranexamic acid. Both groups of patients received the usual pre-hospital, in-hospital, and post-hospital care. The study drug could be discontinued if allergy was suspected or a reason for exclusion was identified later. Doppler ultrasonography was performed to screen for deep vein thrombosis around day 7. The study was designed to detect a difference of 9 percentage points between groups in survival with a good functional outcome at 6 months. The authors calculated a sample size of 1,184 patients, which was expected to provide 90% power to the study at a two-sided alpha level of 0.05. Now, what did they find? A total of 1,310 patients with severe trauma were enrolled and randomized. 50 patients declined participation in the follow-up. 119 patients could not be contacted. So this left 572 patients in the tranexamic acid group and 559 patients in the placebo group for the primary outcome analysis. The patients were well matched at baseline. Most injuries were blunt, 92.8% in the tranexamic acid group and 91.4% in the placebo group. Systolic BP was less than 90 millimeters mercury in 72.6% of patients in the tranexamic acid group and 71.1% in the placebo group. The median injury severity score was also similar between the two groups, and most patients received the first dose of tranexamic acid or placebo within the first 1 to 2 hours. Protocol violations occurred in 32.7% of patients in the tranexamic acid group and 37% of patients in the placebo group. Open-label tranexamic acid was administered in the hospital in 16.5% of patients in the placebo group. So there were quite a few protocol violations, which we'll discuss later as well. So what outcomes did they look at? The primary outcome was survival with a favorable functional outcome at 6 months. So a favorable functional outcome at 6 months was defined as a score of 5 or above on the Glasgow Outcome Scale Extended, or the GOES score, which essentially is 5 is lower moderate disability, which means the patient is independent but unable to work or go to school or continue with all previous social activities. So that is 5, which makes the patient independent, but not quite able to continue with work, go to school, and indulge in previous social activities. So 5, 6, 7, and 8 constituted a favorable outcome at 6 months. On intention to treat analysis, there was no significant difference between the tranexamic acid and the placebo groups in survival with a favorable functional outcome at 6 months. It was nearly identical, 53.7 versus 53.5%, risk ratio of 1, and the confidence interval, of course, did not show any significant difference between the groups. So the functional outcome at 6 months, survival with a favorable functional outcome at 6 months, was not different between the two groups. And they also looked at the primary outcome among predefined subgroups of patients based on age, mechanism of injury, blunt versus penetrating, time to intervention, the initial systolic BP, initial GCS, and the abbreviated injury score for head and neck. None of these subgroups showed a difference between tranexamic acid and placebo. What were the other outcomes that they looked at? They looked at the secondary outcomes, which included early mortality at 24 hours was 9.7% versus 14.1%, tranexamic acid versus placebo. The 28-day mortality, 17.3% in the tranexamic acid group versus 21.8% in the placebo group, significantly lower at 24 hours and at 28 days. So that was an important finding. Mortality at 6 months was lower in the tranexamic acid group, but the difference was not statistically significant, 19% versus 22.9%. However, mortality attributable to bleeding was lower in the tranexamic acid group, 29.3% versus 36.1%. Vascular occlusive events, which you might expect to be higher with tranexamic acid, was not in fact the case. They occurred at a similar rate in both groups, 23.6% with tranexamic acid, 19.7% with placebo, the difference being not statistically significant. The incidence of different types of vascular events, including DVT, pulmonary embolism, myocardial infarction, ischemic stroke, and other arterial events were also similar in both the groups. So the study essentially suggested that tranexamic acid may reduce hemorrhage, improve survival. But if you look at these survivors with a favorable outcome, it was not different between the two groups at 6 months.
Thanks, Dr. Chakos. I guess the results are not surprising for many reasons. And I think just looking at the trial first on its merit, it's a very well conducted trial with a really good internal validity. And also in conjunction with CRASH 2 trial, the external validity is really good because CRASH 2 tested the hypothesis in less developed countries, while the PASH trial tested the hypothesis in a very well developed advanced trauma system. So overall, the tranexamic acid does reduce the 28-day mortality in patients with trauma. So I think that message is really loud and clear with regards to the intervention itself. When you look at the trial, the consort diagram, the loss to follow-up was 13%, which is slightly more than expected, but still good follow-up overall. And almost more than 80% of the patients managed to receive the tranexamic acid within first 2 hours, which is quite a huge success. Now, someone might argue that almost 20% of the patients in each group did not receive tranexamic acid for more than 2 hours, and that there was a delay. And if those patients would have received the tranexamic acid in less than 1 hour, the things would have been different. Using the cost score for randomization, I think that's quite a novel approach to use in terms of the future trials. And then coming back to the strengths of the trial, it does confirm the finding of the CRASH 2 trial in advanced trauma system. So that's the first and foremost thing. As I mentioned before, very well conducted, robust RCT using the placebo, the allocation concealment, and all the benefits which are associated with the randomized controlled trial design applies to this trial. And the key factor with this trial is it tested the hypothesis in a pre-hospital setting. So really trying to address that time criticalness with regards to tranexamic acid, because most of the previous trial did show the benefit of tranexamic acid in that less than 3 hour. And almost by the time patient comes to emergency department, sometimes with remote settings, usually that takes more than 3 hours. And I guess that's why most of the trials where the benefit was not shown, one of the limitations was tranexamic acid was given after those 3 hour window. So I think this trial really managed to get tranexamic acid to the patients in that golden hour, which was pretty amazing. One of the major concerns with regards to tranexamic acid has always been around the potential risk of thrombotic complications. And especially when the patients had a severe TBI and those patients cannot be anticoagulated for a certain period of time. I think this trial did test that hypothesis. And again, there was no significant increase in DVT or P in the patients with tranexamic acid. So again, this is really important study which showed that tranexamic acid is quite safe to use in patients with trauma who are bleeding. Now, coming back to the kind of some of the limitations of this trial, the first and foremost is 13% data was missing, and mostly because of the loss to follow-up. Now, the things would have been different, but having said that, the authors did perform both per protocol and intention to treat analysis. There was no difference in the results using both analysis. The second one was, again, some of the patients did receive open label tranexamic acid or did not receive all the intended dose, which was 1 gram in pre-hospital setting and 1 gram over 8 hours once they come to hospital. and some of the patients did not receive those kind of that full dose. Having said that, again, due to the intention to treat and per protocol analysis, there was no difference in this outcome between two groups. One might argue that generalizability of these findings may be limited to, again, advanced trauma setting, because most of the patients in third world country won't be able to receive tranexamic acid in that golden 1 hour. And again, I think the message is now loud and clear that we have to give that intervention really early to save life. And then the fourth limitation is probably the trial had insufficient power to detect clinically important heterogeneity of the treatment response in penetrating trauma, because most of those patients were involved where they had a blunt trauma. And again, we probably know that in penetrating trauma, the key thing is the damage control surgery or getting them to the healthcare system is the priority. While in blunt trauma, the bleeding and coagulopathy are the dominant mechanisms for further bleeding and death. So I guess it was very appropriately tested in the right cohort of patients. But having said that, we can't generalize this finding to penetrating trauma. So overall, very well-conducted trial and definitely added some more information to our knowledge. One of the things that comes to mind from the baseline table is about how many patients actually do receive the pre-hospital transfusion or plasma transfusion. In Australian setting now, almost 35 to 40% of the patients do receive pre-hospital RBC transfusion, because most of the ambulances do carry 1 or 2 packs of RBCs with them. So I guess that's the kind of where the intervention is actually commenced even before the hospital. So whether that has had an impact, which is hard to predict. But again, both control and intervention group had a similar percentage of patients who received pre-hospital transfusion. So the core question with this trial is why we didn't see the more improved survivorship with this trial. So why the outcomes at 6 months are not different between two groups, or why the patient did not have a good neurological recovery after 6 months. And I think the editorial written by Ian Roberts and Halima Shakur kind of answer that question quite nicely. Key missing piece of the puzzle with regards to any trial in trauma is the post 28-day rehabilitation of these patients. And each health system has still not able to develop a robust rehabilitation system for the trauma patients. And really the 6 months outcomes or the yearly outcome will depend on how good your rehab system is. It really varies between different hospitals and different health districts, even within Australia. And I guess across the world, this is going to be the major challenge to standardize the rehabilitation in order to assess those survivorship. And until we kind of work on that post-intensive care, we will not be able to address some of the issues with regards to survivorship and late 6 months or 1 year mortality. So that's the synthesis of the trial from my side. Do you have any other points to add, Dr. Chako?
Yes, Swapnil, you hit the nail on the head, really, when you were mentioning about rehabilitation post-trauma. That's one of the most important components of post-trauma care. And when you assess the disability at 6 months, it plays such a crucial role that there may be many patients who continue to improve after 6 months and in whom it may be more appropriate to assess the functional outcomes at a later time, say perhaps at 1 year rather than 6 months. And you might find a difference at that point of time rather than at an earlier point of time. Second is, of course, the time frame involved. In India, as you know, many of our trauma systems cannot really get your patients to the hospital or get an ambulance on the way within the stipulated time frame. So it might be a challenge to many of our ambulance systems. Although things have improved over the last 10, 15 years, it still leaves a lot to be decided and to be improved upon. So that is a challenge to us to administer this medication within the time frame that we have. And I think overall, the findings of the PATCH trial just echoes the findings of the CRASH-2 trial, as you rightly mentioned, in that it does improve survival, early survival, particularly at 24 hours and 28 days. That is indeed important. And death due to hemorrhage is also significantly reduced with the use of tranexamic acid compared to placebo, as we saw in this trial. So there is no doubt that it is a very useful intervention, particularly given the fact that there is no increased incidence of thrombotic events in any of the major trials that we've seen so far. Of course, there have been some smaller trials that have suggested increased incidence of thrombotic events. And by and large, it doesn't seem to result in any significant increase in thrombotic events. So that adds to the favorable profile of tranexamic acid. At the end of the day, you really have very little to lose, even if you give it slightly later in the day or when it is not really absolutely going to be useful. So on the whole, I think there is a strong rationale for the use of tranexamic acid as early as possible in bleeding trauma patients. It can only help. The possibility of harm is indeed quite low.
Yeah, that's correct. And I guess that's the key message with this trial is don't go away with the message saying that tranexamic acid does not improve the survivorship. That's why we should not administer tranexamic acid. And that's clearly the wrong message. But in fact, the tranexamic acid saves lives. And we do not know we cannot predict which patients will survive with a GO score of 1 or 2. In that setting, we shouldn't start predicting early and withhold a treatment, which is a more life-saving treatment. And I think that's the main message with this trial is it won't change my practice and it shouldn't change the practice across the globe of administering tranexamic acid. It just reminds us that not everybody who receives tranexamic acid and whose life is saved because of tranexamic acid will be able to achieve the meaningful neurological recovery down the lane. And there are a lot of other factors which will play a role in the meaningful survivorship. And I think that's the key take-home message from this trial, because the disability post-survivorship is not a constant characteristic of a person, but it's a result of the interaction between the person and the environment, which changes over the time. And we cannot control the post-survivorship environment at the moment, even with the best possible intentions. So I guess withholding the tranexamic acid based on the message from the trial saying that it does not improve the survivorship, that's not the right way to interpret the results of this trial. So the key message is tranexamic acid does save lives. So thanks, Dr. Checker. So that's the end of our today's podcast. So we'll be back in another fortnight's time with another episode. So till then, goodbye and have a nice time.
Thanks, Swapnil. Thanks, everyone, for listening in. We'll meet again next time.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.